Good morning, everybody. Welcome to day 2 of West Virginia Law Review's Appalachian Justice Symposium. We're really excited that you're all here and excited to have all our panelists here. The first panel that we have today is on Appalachian healthcare, barriers in the government programs that address them. There's a broad health disparity between Appalachia and the rest of the country that has existed for a long time and is worsening. This panel will discuss some of the healthcare challenges facing Appalachia and government efforts to address them with the goal of better understanding how policy targets the region. Mr. Robert Davis will be moderating.
Good morning, everyone. I'm an attorney at Charlotte Center for Legal Advocacy, and I'm going to start by introducing the fantastic panel that we have. There's additional information in the materials that you all have, so I'm going to be brief. Right next to me is Stephen Butera. He is an attorney with the VA, and his duties include advising related to VA medical facilities. To Mr. Butera's right is Hilda Heady. She is a national expert on veterans issues, homelessness issues, and rural health. And she is also a senior fellow at Atlas Research. To Ms. Heady's right is Leah Heimbach, who is president of Healthcare Management Solutions in Fairmont, West Virginia. She deals with a variety of Medicare facilities and the requirements for that type of funding, and is also a graduate of West Virginia University School of Law. And to Ms. Heimbach's right is Jennifer Oliva, who I think you all probably know as a professor at West Virginia University, and teaches courses including healthcare law and policy. So before I start asking questions, I think one thing that I would want people to keep in mind in terms of this panel is what access to healthcare means to them individually. Does it mean just going to a doctor? Does it mean outcomes and things of that nature? So I'll start, Ms. Heady. There's a trend towards increasing recognition of social determinants or social factors of health when examining health policy and outcomes. Mm-hmm. What are the social factors that affect access to health care in Appalachia?
Loaded question. It depends on what part of Appalachia you're referring to, and it also depends on what group of people may be attempting to get access. But one of the things throughout my career that has frustrated me more than anything about transportation, about access, is the mindset of most people, most policymakers, and most non-Appalachians is to immediately go out there and buy a bus. You know, that to look at transportation. Transportation is only one small part of this issue. Access is complicated by availability of services. The availability of services, of course, is then complicated by cost, health professionals, location, a number of other issues. So access itself cannot be solved by transportation. It cannot be solved by education alone. It cannot be solved by health insurance. You have to look at all of those in combination to look at very successful programs. And some of the healthcare access programs in Appalachia that has been most successful have been those that have attempted to address all of those issues. And so we did see an upsurge when the Affordable Care Act came in. We did see an upsurge in rural people getting more access in Appalachia. It was absolutely a wonderful thing. Not all people were welcoming of that. Not all providers saw that as a boon. However, we have definitely seen an increase in coverage of that population through that program. And so I think the takeaway is don't try to oversimplify healthcare access in rural areas when you look at that issue.
And this is open to anyone. Is there stigma related to mental health? Does that affect access to health care in any way?
Absolutely. Absolutely.
And what are some ways of trying to address that?
You know, stigma reduction is a really tricky kind of issue to look at. Right now in the fields of psychology and social work, it's a booming kind of thing to train in. In the homeless work that we do training with the VA on working with homeless veterans and other marginalized veteran populations. But the one thing that we know clearly is that the stigma problems start in the provider population. Okay, so we have to do more education and training with psychologists, social workers, lawyers, doctors, nurses, everybody, because to me, the kind of stigma that is in our professional ranks is so insidious that, people can be, I support veterans and I'm not, this and that and the other, and without knowing how paternalistic their views may be and how much that view prevents intervention or prevents a good, healthy outcome between the relationships with the patient and that professional.
And Robert, if I can add to that, and from a veteran's perspective, from the VA's perspective, what other segment of population is taught to be tough and strong and stand up and
Exactly.
don't reveal those things that might be affecting them?
Exactly.
The VA has really taken steps to get out there and say, it's okay for you to come and stand up and say, I have an issue I want to talk about, whether it be mental health issue or any type of other issue. And we seek out those folks in order to break down that barrier, in order to provide them with the care that we can do. And we've been putting a lot more money into that area because it is obviously a gap that needs to be filled. So as he was talking about,
Right.
It's that population we have to get to. And
Right.
the VA has, in certain areas of the country, and even in north central West Virginia, where there's 26 counties, we have a population, a veteran population, eligible VA population of about 75,000 veterans. And the Lewis Johnson VA Medical Center had a rural mobile health clinic. So
Right.
all the factors that you spoke about, Leah, about getting the bus and the transportation,
Right.
we put that all together, and we actually went out to the veteran with a clinic that had satellite communication back to the facility, and it had a doctor and a PA and a nurse, and we would go to we would bring the health care to the veteran.
Right.
But how often can that happen? Is it economically feasible for everybody to do that? And it's not.
It's not economically feasible for the civilian population
Correct.
to get that kind of
Yeah.
care. But when I talk about the models that pull all of those access factors together, the VA has done it and done it well with their rural mobile clinic program. And if you're going to provide primary care and mental health services in a mobile vehicle, in a mobile fashion, those are the two most successful, unless you also put telehealth with it. If you do telehealth with it, then you can do a lot of screenings. Dermatology is one of the most efficient and efficacy-driven programs. And the VA is also doing an awful lot of telehealth. There's a lot of VA telehealth out in the out west, where the distances are much further apart.
I work on a daily basis with our telehealth home-based primary care folks, and yesterday I had a consultation with them regarding a legal issue. So we have these intra medical legal partnerships that we have with our VA clinical staff. They know that they can come to the Office of General Counsel, to, in my case, the North Atlantic District South Office attorneys, and say, hey, I have an issue I need some help with. Then it's up to the attorneys and paralegals within my office to figure out where we can get them the help, because obviously we don't do that. And thankfully for me, we've partnered with the law school and Professor Oliva's clinic, outstanding clinic, that I refer to them many contacts that need to be addressed.
Professor Oliva, did you have something?
Yeah, and a couple points of the stigma that I want to make is that and I'm going to be a little more negative. I'm just going to say it from the jump, is that one of the populations that is incredibly similar to veterans insofar as physical risk and manual labor jobs is basically our workforce in West Virginia. So people who've worked in coal mines or done really intensive physical manual labor jobs. And what we see similarly happening with the veteran population and that population is that pain has been addressed by giving somebody a pill that they're maybe even taking secretly because of stigma. They don't want to go get treatment. These are like tough guys. They just want to get up and go to work in the morning. I interviewed some coal miners who were veterans this summer who told me, of course I'm going to take the pills because I can't let my team down. If I don't show up, that creates a whole bunch of other problems. It's a huge cultural dynamic. And then we told providers, stop prescribing these pain pills all at once, all of a sudden, which is not how this particular treatment regimen works. You have to taper up and taper down. We know this from studies. We cut them off. I have veteran clients, one in particular I'll talk about, Iraq, Afghanistan veteran, stepped on an IED, literally shredded his leg and 2 testicles, from northern West Virginia, comes back home, is on an incredible opioid regimen. VA, doctors start taking a lot of heat for prescribing. They ramp that down and literally prescribe him from a high dosage opioid regimen for a person who has incredibly painful and significant physical injuries to yoga and acupuncture. Now, I'm all about yoga and acupuncture, okay? This guy's told this. He starts driving to Ohio, where other veterans live, to get pills so that he can continue on with his life. He's picked up by law enforcement, and he's doing 5 years at FCI Hazleton right now for drug trafficking. So one of the things about stigma is it starts in the front end with providers and these kinds of things, but the real issue is that we can contribute to is this law enforcement first, dealing with addiction and mental health and behavioral health issues as criminal behavior instead of treating them as the healthcare issues and diseases that they are.
If I, that is the impetus, that's really the focus on trying to get the veterans courts established within the state. And our guest speaker for lunch, Judge Loy, and I had this conversation when he was a state court judge, and now, of course, he's a magistrate for the Northern District. We need folks like that to advocate for veterans so that we could identify that type of individual and focus in on providing him the treatment and not saying you get a pass for doing what you do. Everybody will have to pay, certainly, but there should be some consideration behind the scenes, and that's what we try and get to. And the VA's standing there ready to help. We just have to have that conduit between the court and the VA established.
And Professor Oliva, you mentioned something that is sort of related to the stigma, but is the mindset of you just suffer through whatever health issues are going on. And there's some data that indicates that even when access levels are the same, so people are sort of getting the same number of services, the outcomes in particularly rural areas of Appalachia are worse. Does anyone think those two are related? And can anyone talk about sort of how if you're accessing issues, access alone may not be enough, particularly for chronic health issues?
Well, I'll just say one more thing about that in a minute to the panel. I completely think that that's true. I think the data absolutely supports that in social determinants of health, which you talked about right from the beginning of the conversation. And people don't have time and the resources. When someone tells you if you're working a mining job or whatever, and these jobs, you're going to lose your job if you don't show up to work. You don't have time to rehabilitate and rest for 3 days or wean off the pain pills. You still have to show up and do that job or do that work. And soldiering is similar to that. I mean, that's why it's so interesting to me, because I'm hearing this mindset from different groups of people. I think that sometimes us sitting up really high in the ivory tower said, I can take a day or 2 off work. I can rest on Sunday. I can do these kinds of things. And other folks don't have the financial resources and the ability to do it. But there's also a real cultural stigma by not manning up, getting up out of bed, and going and doing that job. And you're letting down other people in your community and these very close hold communities. And that is the absolute reality for a lot of people in these really tough manual labor jobs in southern West Virginia.
I'd like to address the population that's not veteran necessarily, because my background in work deals with regulation. So we deal with the regulatory impact of especially nursing home populations, hospital patients, but the people in West Virginia and in Appalachia in general who are unemployed because work is hard to find. The addiction is a huge problem. I just came from a conference last week in Baltimore where West Virginia has 59 per 100,000 people die from a drug overdose, usually opioids. So during that presentation was something that happened right here in North Central West Virginia called Communities of Care in West Virginia. So there's a stigma with people being addicted to drugs. We have a huge death rate. I lost my younger brother to an opioid overdose, and it's a real hot button for me. So the stigma that comes with it is if you're addicted to drugs, you're worthless. They find the right people that keep prescribing, and then as you alluded to earlier, the brakes were put on when this started getting national news. There's now a national agenda to try and decrease the incidence of prescribing opioid-related narcotics, but that is a really tough sell. And I worked for 25 years as a nurse, so I can tell you addiction is a huge problem. It's a huge stereotype, especially in Appalachia and in this state, because dealing with this, the consequences of it, they get addicted, they end up losing their jobs. It's a cyclical thing. It takes rehab usually more than once, and so you lose your ability to make a living. And so we're often stigmatized because of that addiction, that you're no longer useful to society, and it is a really tough road to hoe. But it's happening here in North Central West Virginia based on communities of care where there are alternative therapies besides opioid prescriptions being done. There's job skills being offered as long as they meet certain criteria to stay within the program. And so I think it's a tremendous problem in Appalachia, especially West Virginia.
And the rise in opioid use has also been tied to pharmaceutical marketing related to pain relief, which has come up. For example, some pharmaceutical companies were marketing pain as the fifth vital sign and encouraging opioid prescriptions. Not surprisingly, as the government share of paying for opioid prescriptions rose, that's when a lot of the opioid epidemic and problems occurred. In these cases, you have an appropriate goal of understanding the impact of pain on a patient's life linked to unsafe practices. Are there ways that agencies can guard against these kind of issues?
Against prescribing them?
Against pharmaceutical companies sort of pushing them to do things that are not necessarily in the best interest of their patient, but are tied to issues that are helpful. Yes, Professor Oliva.
Thank you for asking that. I mean, what the story is with the Pain magazine article that led to this whole pain is the fifth vital sign was there was a small study done in a Massachusetts hospital of chronic care patients that were basically in ICU. And the study came out and said only 4 people who have ever been prescribed this, over hundreds of folks, this physician who did the study, got addicted or at least physically dependent, because we use those words completely interchangeably, but that's not right, on opioids. But the setting was in hospital treatment for acute conditions, right, pre-release from the hospital. So this came out. At the same time this is coming out and this is getting pushed, the pharmaceutical companies are loving it, right? They've always had this product. I mean, like opioids was a cough medicine in the 1800s, okay? If you wanted to get high on opioids, it wasn't hard. You could just go downtown to your community pharmacist. It was easier during Prohibition to get heroin than alcohol. So we have this long history of this in the United States, and at the same time that that's happening, we have medical schools across the United States that have never once had a single bit of training on pain. In fact, that's just started to happen. So it was a very disparaged field. It's part of the stigma issue. People didn't want to treat people who suffered substance abuse dependency or addiction, and there was no training for this whatsoever in medical schools. So now you have this, pain is the fifth vital sign, all I have to do is give a pill. I have no training on how this actually works in the human body or how it operates. The pharmaceutical companies, it was in their interest to keep that thing going. And that's how we sort of had that explosion. And so the data was bad from the beginning on this about how they should be used. So that the pendulum swung from opioids are terrible, people are going to be in a Chinese opium den, and it was very racist, and smoking the dope, and there was no opioids allowed. Then we swung the pendulum all the other way. It's the fifth vital sign with no training, and now we're going back to you can't prescribe opioids at all. I mean, that's just the regulatory scheme that has occurred over the last 100 years in the United States.
If I could add to that, before coming to the VA, I worked for the Drug Enforcement Administration, and after coming off of active duty, and this is something that just didn't happen. We saw it occurring, right? And the big focus, obviously, was the interdiction of drugs coming into the United States. Your marijuana and the other types, but the diversion folks were always tooting horns, saying, "Hey, we got this problem with opioids," and the smiley face, where do you sit on the scale, and what's your pain today? Everybody has a right not to be in pain, and the proliferation of pain management specialists out there that held themselves out to be, was unchecked to a certain extent.
And Ms. Heady and Ms. Heimbach, I know you all have been on sort of large policy groups that have sort of advised on rural health and things of that nature. Can you talk about what that process is like when you're sort of at a higher level, and how you accommodate individualized care in that context?
Okay. The only way to really get from, at that policy-making level and then impact directly to the person is to make sure that at this level, you've got sufficient diverse voices and representation that everybody's kind of notion of what should happen gets heard. And I have been fortunate throughout my, career to be at both levels and kind of see how that process opens up. And of course, Congress legislates, and then the regulatory authorities tell you how to do it. If anything, I would say that the nonprofits or the voice of the consumer kind of organizations need to be as broad as possible in that process as well. And the ones that tend to take just one argument and just, barrel down the rails on that one argument are the ones that everyone fast grows deaf ears to. So to me, the issue is the more diverse the voice, the greater the policy, the more the policy itself can become masterpiece. And so it's part of that process, which I think is your question, is, how do you guard that process and make sure it works?
And I think you had mentioned that you were part of a VA policy group that had considered telehealth, which is a less controversial issue. So let's say telehealth, you have this VA rural health group, and
Yes.
and telehealth is being presented. How does that work? Do they have speakers come in? Can you just describe that process?
Well, I was very fortunate in 2008 to have been appointed to the first veterans, the rural veterans advisory committee to the secretary, and I served on that group for 5 years. And at the Office of Rural Health in the VA started in 2007 as a result of a piece of legislation that I worked on as the president of the National Rural Health Association. So it was kind of developing congressional awareness, public awareness, and then led to this legislation. And one of the first agenda items we looked at was the lack of research on rural veterans. Then the next one was telehealth, because telehealth was seen as the access solution to reaching. So what we did was we educated ourselves, and the speakers, we had speakers from the private sector, speakers from the VA, speakers from the HHS, people that were involved in a policy area with telehealth, telling us what was working, what was not working. We reviewed all of the research and that sort of thing, and then we actually funded some demonstrations. So our committee did not, we didn't give, the Congress gave the money. Their first allocation was $500 million. Wow. And so what we did was we oversaw in the reports from all of the different pilot programs that had been funded by that office. And telehealth was, every year there was different telehealth pilots. Some of them were very successful, some of them weren't. The vans that Robert was referring to, the mobile clinics, that was a funded pilot project too that was done in those early years.
Is there anything unique about the VA that allows it to be innovative or to take innovative approaches?
As a civilian, I think the VA has one of the best environments for innovation because it has a defined, prescribed population. And it has a popular population. Now, anyway, it didn't back in the 60s, not so true in the 70s. But anyway, the American public wants this population served. And so if you've got that, if you've got, apple pie mom and the baby going there down your path, then you can do that. But the VA, a lot of people don't understand this. The VA is discretionary funding. There is no mandatory dollar anywhere in the budget that says go to the VA. So Congress and the VA have to constantly work together on trying to keep enough of a positive image among the consuming population to continue to fund the VA. The VA does have a Center for Innovation that is funded. They encourage innovation among their VA employees. They encourage innovation outside the VA. There are different programs where there's research collaboration and policy innovation collaboration between the civilian healthcare system and the VA healthcare system. The VA is the largest healthcare system in the world. There are some different health professions that are highest employers, like social. There are more social workers employed in the VA than any other sector in the country. And so I think you do have to learn how to work and use that environment, but I think that they do have avenues for innovation.
And I have to add to, not that I think I could, but it's absolutely great, but as a consumer of the VA healthcare system, as a VA healthcare recipient and as an employee, I got to tell you that leadership is in place now that really advocates for it and encourages us to be innovative. The VA, if you didn't know, one of the first organizations to have electronic healthcare records.
Right.
And there's a book out there called The Best Health Care Anywhere, and it's absolutely true when you read it. You don't see it touted on the news, right? You see other things that are portrayed in the news, but the other things that the VA is innovative of go without saying. But we know it on the inside. I mean, it's there, and obviously it's getting out to folks like you. But again, as a patient, I'm very thankful for the VA system and how
Right.
it works.
And just one other thing, because I know that we all have had different experiences and heard horror stories with our veteran population. And to me, the key factor that is absolutely different is what he said, leadership. And so there can be a tremendous disparity between your leadership at the secretary level and your leadership at the VAMC level.
Right.
So that is the key. And so most of these quality issues, these frustrating stories you hear, if there's an analysis done of the leadership pattern, I think that's where your key is.
Yeah, Dr. Shulkin, just from day one, been advocating it. Our new general counsel, Jim Byrne, out there and going out and making it happen and allocating resources to it. And locally, my boss in the North Atlantic District South, Dan Rattra, constantly encourages his staff to go out there and be at the forefront of this.
And Ms. Heimbach, just to switch gears to Medicare a little bit, I know you work a lot with Medicare's conditions of participation. Can you describe what that is, those requirements, and anything else that you think might be important for people to know about those?
Sure. So in order for a healthcare facility to bill Medicare or Medicaid to get reimbursed, especially in the Medicare realm, and our biggest focus right now primarily is in nursing home industry. New regulations passed November 28th this past year that requires nursing homes to meet conditions of participation in order to bill. So a big part of our work is that we employ healthcare facility, we call them surveyors, but they're more inspectors. They go on site in nursing homes, hospitals, dialysis facilities, intermediate care facilities throughout the country and territories to inspect those facilities unannounced to see if they are in compliance with the Medicare conditions of participation. You may or may not be seeing news stories. There was, I think, something on national news this past fall about a nursing home in Florida where there was flooding and patients died, and there was a hospital right across the street. So why did that happen? So our inspectors go on site, look at medication passing, review medical records, interview staff, observe care, inspect kitchens, food temperatures, and there's just a huge population that's at risk there, especially in the nursing homes. And our surveyors write a report that's submitted back to the Centers for Medicare and Medicaid Services, but oftentimes they discover something called an immediate jeopardy, where there's an imminent threat to life or safety of the residents in the nursing home. And when that happens, they have to stay on site until that's abated. And then there are other follow-up consequences that come from that. But it's a huge regulatory impact, a much needed one. And whatever your politics are aside, there is a shift where it's more patience over paperwork and less burdensome reporting requirements for facilities, which I get, and quality measures being used to assess outcomes of care. And that's all well and good and needs to happen, and you don't want to overburden providers to do mandatory reporting in order to bill Medicare and Medicaid. But on the flip side of that, you also have to protect the most vulnerable populations, and there's just story after story after story in the national news where that's just not happening.
Do you notice, in terms of the inspections of facilities, are there general differences between rural and urban facilities?
I think there's more of an incidence of being impacted in rural areas where there are staffing shortages. That usually is what drives it. I mean, I think every nursing home in the industry wants good care for the residents of those facilities. The problem is they have budgetary challenges, workforce challenges, trying to be able to recruit people to work there. But I also have to tell you, and this isn't a generalization, there are larger chain-operated facilities where it's more of a real estate business. And some of the evidence of the inspections that we're doing are that they're doing cost-cutting measures. There's one instance in a part of the country not near here where we had an immediate jeopardy discovered because a nursing home resident had not received their insulin for 6 weeks, and it turns out that there was a problem within that particular nursing home because they didn't want to buy the glucose test strips because of the cost associated with it, and it became an immediate jeopardy for this one. But you can imagine how many of the diabetics are in that nursing home, who else didn't get tested, and so that caused a big uproar and change that had to happen. But had we not been inspecting, that could have continued.
And as a former CEO of a small rural hospital and you know, very much involved in the entire rural health care industry, I get very sensitive to the whole issue of quality and people saying, well, it's rural, that's substandard quality. Nothing could be further from the truth. And so Leah is absolutely right. What we have seen is that when the healthcare industry, whether it's urban or rural, but most particularly rural, gets driven by economic realities, the quality is not necessarily always improved. Right. And these kinds of scenarios that she's referring to, again, leadership is the issue. And what we see happening when these large healthcare systems and chains come in and buy out small rural facilities, there's a tremendous turnover of leadership, so that the individual leaders themselves might not necessarily be of a mindset that's creating a quality problem. But the fact that there's this tremendous amount of turnover and the CEO is not from the community and on and on and on, you can create systemic quality issues in those facilities. But most studies, if you look at them, the studies and the quality of healthcare outcome in rural communities, if they are a community-owned based hospital, many times those rates of quality are much higher than they are in other areas and other management systems.
And just quickly, you know, people may not know, but the VA is held to the same standards as such as a Ruby is under the JCO, the Joint Accommodations Act. So we have to obtain the same type of quality, no matter where we are in the state of West Virginia. We have 4 VA medical centers. I don't think you'll find that in any other state in the country, along with the community outpatient centers. Doesn't include the contract facilities that we have for nursing homes, right? So we actually send people out in our own, quality standard inspections, as well as being held to that highest level of healthcare standards through JCO. And the VA is compliant in those areas. So you come to a VA hospital, you're going to get the same quality health care as you would go to a larger, university-based learning institution type of a facility.
Right. And we do have 4 VAMCs, but each one of them is in a different VISN, a different Veteran Integrated Service Network.
Right.
That does not impact the quality. If anything, it impacts the monetary distribution, the funding issues, or can create problems in that area. But in West Virginia, I mean, I'm sure all of you know that we have a very high proportion of our population who are veterans. And at one time, we were the highest in the nation, not any longer. But also, we have one of the highest enrollment rates among rural veterans. We've got 78% of all of our rural veterans are being cared for by the VA in West Virginia, and that's one of the highest rates in the country.
Excuse me. It came up earlier that, a lot of work in Appalachia and West Virginia is labor intensive, and some of it causes increased rates of physical injury, things of that nature. How does that affect the type of medical care that's needed and the type of facilities that are needed?
Well, we need more. I don't know if everybody knows this, but we have more disabled Americans living in the South than any place, and in Appalachia. Part of that has to do with the extractive industry. We just have really, really hazardous jobs. But we also have some of the fewest physical rehabilitation facilities. So a part of it, when you look at the broad spectrum of care, all the way from the acute injury or the chronic injury all the way up through rehabilitation, there are breakdowns in our areas in each one of the spots in that chain. Now, not a breakdown in the VA system, a breakdown in the civilian healthcare system.
I think that's also impacted by the lack of providers.
Yes.
Especially specialists in Appalachia and especially in West Virginia, that also presents a challenge, because then they have to travel further away out of state to get specialty care or rehabilitation that's intense and those kind of things. And as you mentioned earlier, you can't take time off from work to do that.
Right.
So it's,
Well, and one of the biggest breakdowns of care in that is mental health. I mean, there are more mental health shortage areas in rural areas than any other type of specialty, even more than primary care, more than dental care.
And the VA's other challenges regarding the capacity, in the sense that, you always hear that there's thousands and thousands of jobs that go unfilled. Well, believe me, they're advertised. But it's difficult to attract a quality cardiovascular surgeon to Clarksburg, West Virginia, or to another rural part of the state, when they can go someplace and make 4 or 5 times that amount of money. Of course, they're limited by what Congress says we could pay people.
Right.
And I don't think people realize, you could walk in off the street if you're a clinical provider and hand your resume into the Human Resources Department and apply for a job that way. You don't have to go through the whole other and the process will start. So it's difficult attracting those quality of individuals in, but we do. It's just harder.
What steps can be taken for, and just as an example, Medicare does have some bonuses that they will pay. Some data shows that those aren't necessarily effective at recruiting people to rural areas. Are there steps that the VA has found as particularly effective, or that other people have found as particularly effective to recruit?
Training. And of course, for 18 years, I was the Associate Vice President for Rural Health here at WVU. And so I really understand that strategy, the education strategy, training and service obligation. The VA has a tremendous program in this through their academic affiliations with medical schools and nursing schools all over the country. But the thing about training is you have to include the realities of the service environment as a curriculum requirement. And we did that in West Virginia. We had a 3-month rural rotation required of all health professions in the state. We had that requirement in place as a degree requirement for 12 years. It made a tremendous difference. We had actually the Shep Center at North Carolina did a study on West Virginia, and West Virginia in 20 years completely reversed the origination medical school of the entire physician workforce in the state. And so if you train people who grow up in that community, you educate them, give them what they need for their undergraduate, graduate, their high school diploma, then you put them in an environment where they're trained to appreciate their own home community, go back and do some training there. They will stay, and we've seen that happen in West Virginia and North Carolina as well.
And Ms. Heimbach, you run a business in West Virginia. Can you talk a little bit about the challenges and maybe the rewards of running a healthcare business in West Virginia?
sure, it's not easy. I too have challenges with finding the right workforce, and part of what we do requires special certifications for the folks who do the inspections and those kind of things. You know, I spent the majority of my life trying to figure out how to get out of West Virginia. I'm from here, and when I could, I had spent enough time working and traveling in other areas. I just decided this was a really good place to be. I can go where I want, when I want, but I like it here. I mean, it's got a good educational system, the lifestyle, lower death rate by shootings, many pluses for it. But the challenge that I have is finding a committed workforce that gets the mission of what we do. You have to care about what you do and be passionate about what you do. I really was very blessed in evolving into serving nursing home residents throughout the country, because it's a really difficult population to deal with. It's a booming industry, and if you don't have someone in a nursing home in your family, you probably will, and eventually you will be there. So it's sort of paving the way for where the next generations may end up residing. But the pluses are that it's you can pay people a little bit lower here. I also have an office in Columbia, Maryland, right outside of Baltimore, and they have a little bit higher pay scale because of the cost of living there. The other challenges from a regulatory standpoint are business taxes, and you know, with the new tax reform, we'll see what happens with that. But it's just being committed enough to know that if you're going to make an impact nationwide and you can be in West Virginia, there's so many benefits to being here. Ease of use, lifestyle for the employees that work with HMS, the impact on the local economy of where they spend their money. So I find it to be very rewarding, challenging, but very rewarding.
And Professor Oliva, do you run into the same type of issues with law students and staying in West Virginia and inspiring them to public service? Is there a tie to that for the legal education?
Yeah, I mean, I think all these things are interconnected. You know, one of the things we've been talking about a lot at the law school is getting people to do rural rotations, and lots of the students are interested in doing that. But you need some resources and supports up front. It's the same thing as trying to send a solo practitioner who does gerontology down to McDowell County, right? You need some social supports. The spouse has to have a job. The schools have to be good for the kids.
Right.
So we have these, it's never one answer, right?
Right,
You can always
right.
send someone that lots of people want to go home here.
Yes.
My
Right.
students are constantly telling me that. If we pick up a case that's anywhere near anybody, Pocahontas County, from Pocahontas County, they're going to get in the car
Right.
and drive. I can't stop them from going down and serving that veteran. And then they want to do that. One of the things that's nice about VA work, I'll say this for the students, is a little helpful compared to some of the other areas of public service work, is that you can get paid at the end. That was never the system. They always kept lawyers out of the VA, right? You could never represent veterans and get reimbursed. But the system now is such that you can get reimbursed at the CAVC, at the federal court level, if you represent veterans and are successful. The problem is that you need that front-end supports because it takes, 3, 4, 5 years to build up a practice like that because of how slow the administrative law process is prior to reaching the pay system. So you have to, so I'm hoping to build a network here of people that are doing that, making referrals, and they can start picking that up as a side piece. Because let me tell you something, we cannot serve the number of veterans that need services in this small clinic in this state. It's a real specialty practice. And the nice thing about reimbursement with veterans is you don't take anything away from the veteran. The federal government pays the attorney fees for you to represent them. So you also can kind of go to bed at night with a clear conscience. You're not taking, 33% of whatever your client's getting after a 15-year fight for a disability reimbursement.
Yeah, and if I can add, obviously, the rules regarding the VBA, the Veterans Benefit Administration, and representing veterans within the appeals section, and attorneys have to be certified.
Right.
You just can't walk in. And for the longest time, it was at such a low level of the reimbursement, you couldn't find attorneys that would participate. However, that changed, a couple of decades ago, where actually there was a lawsuit brought by veterans saying, hey, we can't find attorneys to represent us. You need to increase the rate, and they did.
And we're talking about the rate. Okay, let's just
Yeah,
tell
yeah,
this
yeah.
story. This is really what the law was in the United States.
Civil
okay?
War
In
time,
the
right?
Civil War, okay? In 1962, if you got a lawyer to represent you all the way to the Supreme Court of the United States, wherever you went in a veteran's claim, the maximum reimbursement you could get was $5. Now, maybe if we go back to the Civil War and look at that, we'll be excited. 2 years later, these Civil War veterans are really wanting representation, and they come back and they say, you've got to up the fee. They doubled it, $10. Now maybe again that sounds good in 1865, but it was $10 until 1990.
Yes. Wow. Yes.
The law that was passed in 1988 that finally changed that went into effect in 1990 and created the Veterans Court, finally allowed people to get reasonable attorney's fees and get reimbursed. But from 1865 to 1990, you could get $10 on your way to the Supreme Court representing a veteran.
That's right. And real quickly, you're right. The buy-in of the employee is so important. And at the VA, I keep on going back to the VA, but obviously that's why I'm here. The employees don't. It's for 99.9% of them. It's not a job. They come there to work for their veterans. You want to say, I'll often have somebody call, my veteran needs this. They take it as a personal mission. And a lot of us are veterans, so it's sort of just a natural offshoot to what we did before. We're always going to, be with our buddy and protect their six and got their back and that kind of thing. And I get phone calls all the time that are out of my lane, but I certainly just don't hang up the phone. I make sure that I find out where. Right, call the clinic. But I follow up and I make sure that they do, or I make sure they need an appointment, I get them to the right people. Because that's what we're supposed to do as employees at the VA. We're supposed to buy into that. We have, an acronym, ICARE, which sums up all of the elements of how the agency, the secretary, and the rest of the staff want us to act. And we try and model our lives by the ICARE. And those of us who do, it's easy to work under that system.
And when you talk about veterans serving veterans, I think that's a good transition into the next segment, which is what we should be thinking about when we're talking about care and policy. And one of the issues I want to touch on is cultural competency. What are some of the issues with cultural competency with serving veterans and things that are important to remember?
Well, you've really hit on my sweet spot here. But in the interest of time and respect for my panelists, I think that anytime you're going to serve a population, you need to understand their culture, even if they're from your same culture. But rural Americans have a really unique kind of view of life, and if you don't know that, then you're going to miss the boat. I think that people from rural communities grow up with a notion of service, and we've tapped into that, and that plays big in when you're trying to train people. But even when enlisting, even the fact that we have more rural whites, more rural blacks, more Native Americans, more Pacific Islanders, those populations that serve at higher than their proportional representation in the U.S. population, almost all of those people are rural. So what they have in common is this notion of service to family, service to others, service to community. And so a lot of studies that have looked at why we have disproportionate representations in the military of certain populations, they've kind of always flagged on, well, they're poor and they need to go to school and this is a job and this is a way to get educated. That, I'm sorry, is a very shallow notion and doesn't get at the full picture. So when you have an option right out of high school and you're going to enlist, if you're from a rural community, you might be worried about whether or not you're going to live through enlisting in that service. But if you have a value of service to others, it makes it easier to make that decision. And so that part of the phenomena is not studied well enough. The National Guard has looked at it, but to me it's a positive part of the culture that we need to recognize and continue to work with. And that's why peer-to-peer veteran programs work with rural populations. That's why it's easier to get rural veterans to engage in the system or go to the site where they have a rural clinic that day if they know their buddies and other people are going to go there and the family's going to go there and be served as well.
Can you describe what peer-to-peer means? Because I think everybody may not have a conception of that, but I know there's a trend towards peer-to-peer services in healthcare.
Well,
Okay.
go ahead. Well, the peer-to-peer program, it's both in the civilian and the VA healthcare systems, and it's where an individual who may have the same kind of health condition or issue is going through and has received health care or has been educated about that condition and then becomes either an employee or a volunteer to then work with their peers who have the same condition. And so the VA actually has great programs to certify. They certify mental health peer-to-peer counselors. They certify, in fact, the program that I did was with unemployed and homeless veterans. They certify previously unemployed veterans to then become voc rehab specialists with unemployed, potentially homeless veterans. And in the healthcare industry, the civilian side, we have a number of community health workers that do the same kind of thing. In the Hispanic community, they're called promotorias. And so we do have, using that concept has been very successful.
Even our veterans legal clinics
Right.
attempt to recruit other veterans that are peers or mentors to help that veteran, through their journey in the system. So it's not just obviously in the healthcare side, it's also on the legal side. And it's proven to be very successful. You have to establish your credibility with that person. And if somebody comes in my office and they talk to me, they see my pictures and my memorabilia and things like that, and they see that I've gone through the same thing that they have, and I could talk to them and give them, my advice, and they take it. Not that they don't trust anybody who hasn't served, but it just breaks down that wall a little bit more, and I'm sort of their peer also.
And it's, it's part of the self-help technology, if you want to say, and one of the most successful, long-standing peer-to-peer programs is, of course, 12-step recovery.
Yes.
And so can you talk about, did it come out of substance abuse primarily? Is that where peer-to-peer started, substance abuse treatment? And does anyone want to elaborate on that, or what areas it might be important to have peer-to-peer?
Well, I think it came out of the family, quite honestly, back in the caveman days, but, because they had to work together, certainly. But in terms of 12-step recovery, I mean, that's what, 70 years old, 80 years old? But it's an anonymous kind of fellowship, so it makes it a little difficult because the principles are not to promote, rather attract. And so I think that the various legal, health, social industries have had to borrow from those principles to get the peer-to-peer system or the self-help system working. But it is by far highly successful when it is in place.
And there's a trend in the VA to actually have AA and NA
Yes.
at the facilities. They're comfortable in an
meetings,
environment,
yeah.
right? And they bring that in. So another innovative way of trying to bring that healthcare aspect, that outreach aspect.
Right,
to
and in the
veteran.
homeless area and employment area, we have seen high successes with those employers who have sensitivity, understand combat veterans, understand addictive issues, that will have meetings on the floor, in the physical plants, or in the back, in the, staff room at Walmart, those kinds of things. Those messages that are sent are really very positive and helpful.
Ms. Heady, we talked about this a little bit over the phone. Can you talk about how homelessness differs in rural populations and how that has affected the treatment of the homeless for government programs?
Okay, homelessness in rural areas is more, the person themselves are not different in terms of their determinants of homelessness. Those are pretty similar, but their adaptation to homelessness is different. If you're in a rural community, it's easier to hide your homelessness than it is, because you're not laying under the street, you're not begging on the street corner like you are in a city. And also, homeless people tend to hate the word homelessness. So we all need to find a different word. The rural person is just out, they're just in between. The in-between word is used quite frequently. And they're just currently without a home. It's not the same thing as homelessness. And so because of the family structures that we find in rural communities, if this person is sleeping on their grandmother's couch, for 3 or 4 days waiting for their check that month, they're not homeless because they always have a place to go. But policies are also different, and the way that they're implemented can be different in rural communities. For example, to be defined as homeless in order to benefit from certain kind of federal programs, you have to have been in a shelter, spent so many nights in a shelter for a 6-month period, and then you're considered homeless. That's the definition, and then you can get care. Well, we don't have emergency shelters in rural communities, and they won't count Mama's bed as an emergency. So, that's a policy that we're trying to change, and so it's different because veterans, the veterans or other homeless people just hide more. They have more, they camp out in the woods, they live in caves, they live in deer stands, they live in abandoned boats, so it's just really more challenging to find them and get them enrolled in services. But the policies too are deterrents to getting them help.
I think you'd all agree too that as an agency, our mission, we've been charged with the mission of ending veterans' homelessness for our population since 2009. And we've significantly impacted upon that. I don't know of
Yes.
any other organization that said, we're going to end this, and we're
Right.
going to put the effort into doing it. And I think our definition of homelessness is even more
Liberal.
restricted.
Yes.
We try to get a lot more people into that catchment group. But you'll find veterans say, I'm okay, give it to the next guy.
Right.
You're living in your car. That's all. I'm okay. At least I'm dry.
Right.
Give that room to. And we have such resources where we have dedicated people out there trying to find these folks, and we have places where we could put them. It's obviously not forcing them, but they have to agree. But we do have those resources on it. And in a rural situation, though, it is much more challenging. to get to them.
And we have fewer employment opportunities in rural areas and fewer transportations to those employment, sites of employment and so forth. But the whole notion of the work that we're engaged in right now is trying to get the VA to look at competitive employment as a reasonable route for disabled and homeless veterans, because traditionally, the VA's employment programs have been hiring veterans to cut the grass and mop the floors. And we're trying to say, that's not working. We got to move to a different mindset.
And we have many, many examples of veterans working for the VA who were severely injured and had multiple, problems. And they're in there as contract specialists, as other, non-labor type of, and that's the whole thing. It takes a while to get them into that and through the system, but we are really leading in trying to make that happen.
Right. The firm I work for is a service-disabled veteran-owned small business, and their CEO, the founder, is a disabled Afghan vet and a surgeon.
And the law provides that, like in construction projects. If the market research indicates that there are 2 or more responsible service-disabled veteran-owned businesses, it's going to go to them in a lot of cases, depending, of course, on the size and the complexity and things like that. But we actually try to get those veteran organizations. In fact, there's a project at Clarksburg being built right now by a service-disabled veteran company. And it's a big project. It's a decent project. It's going to really help veterans that it's going to be done by a company that's owned by a service-disabled veteran and who employs other veterans for the most part. So we try, and even Professor Oliva's clinic, you have veterans in the clinic who are going to school on a GI Bill that they earned. They, in turn, help other veterans. It's really a big bang for the buck that we're getting out of our educational benefits. And these veterans who are learning how to be attorneys but helping their fellow veteran establish great credibility with them, and they help themselves by getting out there and learning about the system before they graduate, and do tremendous service to the veterans by assisting them in their cases.
I agree with you guys, of course, it's a great PSA for the VA and everything that they're doing, but the fact of the matter is that everybody knows there's a huge veteran homeless population.
Sure, absolutely.
Secretary Zinsecki said that was his goal. We're pretty similar to where we were. We've implemented a lot of programs. One of the big issues here, you can talk about how great the programs is that people aren't eligible for them.
Yeah.
And moreover, that veterans came back from combat with severe mental health issues, had bad paper discharges, VA would not give them services, and then they became homeless. So we're always kind of creeping around the corner at the back end, trying to come back in, and look at all the wonderful homelessness programs. I mean, for me, it's that discharge service process. When you get out and you have an issue, you immediately are eligible for VA treatment. That's not the law. But lots of people are not eligible to go to the VA that are veterans. They're legally veterans, or they're not, but they served, okay? So some people who are in the legal category of veterans are not eligible simply because they don't have the type of discharge status that makes them eligible, but they still count as veterans under Title 38. Some people don't even count as veterans under Title 38 because of how they were discharged from service, not because they didn't go to war and fight and step on an IED. So we have people who are really severely damaged and injured serving our country, and when they come back, we let these things happen because we say, you don't get any benefits, you don't deserve any services. Sorry about it, goodbye. Now they're homeless, and we keep having these numbers weeks and days and months down the door. So not to be, the negative one on the panel, but that's a very frustrating situation.
Exactly, but they're not VA rules, right? We follow the rules that Congress has set. So I mean, the VA tries to work, obviously has to work within the rules, and you're exactly right, Professor. The fact that you might have served 20 years in the National Guard, you still might be able, under Title 38, to be eligible for VA care and services. It all depends on your time of service, length of service, things like that. But those are the rules that have been set out, and we have to follow. So that's, I think that has to be thrown into the question also. We don't have this broad-reaching scope that we could take everybody.
Well, and the VA does have some Band-Aid kind of programs where they've attempted, and like the social services for veterans and their families is one of them, and that's one of the programs. We do the compliance review nationally for that program. And those people can serve veterans and family members who might be at risk of homelessness, and help them get their discharge status reviews if they don't fall within that. But the whole notion of status reviews, I think, is absolutely imperative, even going back to the Vietnam-era veterans if they will accept it. But to me, it's one of the biggest policy barriers that we have in terms of both creating the problem and then trying to solve the issue.
And those rules are very nuanced about who can get services, who cannot get services, which, you know, the VA does have a duty to enforce the rules, but in this area and other areas, sometimes certain people don't necessarily know the nuances of the rules. And you mentioned vet centers are a good avenue, but some people may not know about the potential eligibility. Are those challenges? Are there ways to combat? What are the ways to combat those challenges where, say, a social worker at the VA may not know what the exact rules or things of that nature? How can we avoid those problems, or are they avoidable?
Education.
Yes.
Education, obviously, and having the provider or the clinician know where to go to get those answers. Normally, it starts with a call to my office or one of my colleagues, and we're able to, either, answer their question directly to them on how to proceed, or direct them to a place that they can get that answer. So really, it does come down to education, but I don't want it to think that it's black and white and then just, this is either you are or you're not. There's so many different avenues and offshoots that go on that even a person who might not be, a veteran who might not be eligible, quote unquote, under Title 38, there are different things. There's minimum economic or income levels. We're always a safety net, is what I'm going to say. Even if you haven't met all the other ones, if you meet a certain minimum or don't meet a certain minimum threshold on the money, we're going to be there to catch you, that kind of a thing. And from there, everything goes up. I mean, you'll even find that dental care in the VA is strictly rationed, so to speak, to those who are 100% service connected or a POW, rightfully so. But it's one of the things that the veterans can understand. Well, how come I can't get my teeth cleaned, or how come I can't get a filling put in, that kind of a thing. So providers need to know where to go, and it comes down to education, and it comes down to our folks knowing where to send them, or answer the question.
And just so you don't think I'm just picking on VA, I mean, the entire one of the huge problems in the American healthcare system, period, is dealing with things in the back end when they're very expensive and very difficult.
Right.
And now you're in the emergency room, and it's the same kind of stuff. And what I'm asking VA and everyone to do is to shift that to the front end preventative care, when we have people captured, when we can deal with them, when they're in front of us before they slip into such a state of despair. And their health care is, they're depressed, they're suicidal, and these kinds of things. I just think that it would be cheaper and more effective to do it, and it's more humane to do it on the front end.
And one of the things we are fortunate in Appalachia that we have such a strong system of federally qualified health centers and community health centers, in these communities, because veterans can go to those communities. They're right there. That's where their wives and their children go, or their spouses go. And they can get dental care and they can get mental health care in those facilities and still have their VA benefits. So we try to encourage a lot of education among the veteran populations and their dependents about the availability of those services, especially the priority 5 veterans that we have who are low income. They have their benefits because they're low income, not necessarily because they may be disabled.
And we're directing resources to those, but you have to build buildings and hire staff. And in Clarksburg, we doubled the beds, the inpatient beds for mental health, and there's still obviously a need for more.
Right.
So we contract that out, under the Choice Act and through other newly enacted. We could send them out to other VAs. We could send them out to the economy.
And one of the things that we find most productive is in these small communities where there is a CBOC, a community-based operated practice, which is a VA facility, and a community health center, or FQHC, which is funded federally, subsidized federally, when we see them collaborating around staff issues. In other words, the same 2 or 3 doctors work at both clinics. And so that, using their choice benefits over here at one clinic and then going to the VA for their family. One of the biggest problems that we have with rural veterans changing their care from the civilian healthcare system to the VA is their concern that their family won't get service. So
VA doctors can't work at FHQCs.
What?
The QHC?
Yeah, the VA doctors don't have dual employment.
No, they don't. No.
Well, but the community-based doctor has
They
multiple contracts.
Sure.
Yes.
But I'm saying the VA doctors can't.
No, if
No,
they're
no.
employed full-time at the VA, no. These are private practice physicians who get contracts and who work at a community health center and also work at the VA clinic.
And if we don't have the specialist, say, for example, again, Clarksburg, at Clarksburg, and you have to go to Pittsburgh, we run a bus service twice a day to and from Pittsburgh so that you can get to your appointments and get back. It doesn't cost the veteran anything. You just have to get to us so we can get you up there and back. So we try and be, like I said, as innovative as possible and less stressful on the environment, because as you know, we haven't spoken about medical legal partnerships, but to a certain, unless you are concentrating on getting better, if you're how am I going to drive there? What's the weather like? Those are certain things, obviously, that we could address. But there's certain legal issues that, if you're on their mind, you're not going to get better because, or as quickly, or as focusing on the medical aspect of your condition, as opposed to, I'm going to get evicted. What's going to happen? I might go to jail.
And can you talk about the integration of legal issues into healthcare?
Sure. The VA has its, like I said, I think a very good intra-VA medical legal partners we have with our clinical staff, especially when the staff knows that they have counsel to go to. And I know in my district, clinical staff interact with counsel on a daily basis. I know it's true for my practice, and those are my other colleagues in West Virginia, Matt Kelly and Craig Komorowski. We get calls from the 4 hospitals in West Virginia. Picture Clarksburg, Martinsburg, Beckley, and Huntington. Huge VA, I'm saying huge, but very large hospitals that provide a variety of care. And along with that, the community-based outpatient centers. So we have a very big footprint and presence in West Virginia and the rural health program and all the other innovative ideas. But our clinicians come to us and ask questions regarding legal issues that their patients have so that they can direct them to, or I could direct them to, Professor Oliva's. But that's really, that's not, I'm saying that's great, but I don't have a Professor Oliva clinic at every facility. I mean, we're geographically stuck up here in central West Virginia, and she's limited to her staff. So the object is to work with the state bar and to try to develop a pro bono network. But on a national average, the VA certainly is leading and is charged with establishing medical legal partnerships throughout the nation. There's 23 medical legal partnerships at VA bases across the country, and recently a study was done that came out that in Connecticut, New York, I believe, that the folks here, I got some notes here, from 2014, they did a study, and they served 950 veterans through this medical legal partnerships where training was conducted, clinicians were able to identify legal issues, refer them, and it's a very interesting note, there was 1,384 legal issues developed out of those 950 veterans, and it took approximately 5.4 hours of time to correct those issues at a cost of between $270 to $405. I mean, that is really a great indicator of the savings that we could achieve by getting in on the front end and not letting that person become homeless or go to jail or something like that. But it takes that, what's that conduit that we can establish between the clinicians and the legal side? I take a question.
I don't know if you're willing to take questions, but I was curious whether you mentioned that there is rural innovation money, and I am wondering if this might be something that could be a proposal that we could work on as a region to try to, sort of make that more robust in terms of the ability to have some medical legal partnerships that serve the hospitals, the DOMs, the satellite clinics around the state. I think it would be a tremendous project. I work at Legal Aid, and so
yes.
Patrick Brooks and LG and everybody that's come
Sure.
through our short-term veteran fellow project. But we had an SSVF partnership that we found really frustrating for the exact same reasons that Professor Oliva was discussing. Because of the narrowness of the funnel to qualify someone for that funding stream
Right.
to get a legal referral, it was always after they were already homeless
Right.
or
Right.
clutching an eviction notice.
Right.
Right.
And, so many times, if we could have gotten a referral from the clinic or gotten a referral from a provider and gotten in there and done something sooner, it would have obviated the whole necessity for, this sort of triage when it had gone way past where it needed to be.
Absolutely. We need to develop those, and we haven't developed them, but again, the General Counsel Jim Byrne and Secretary Shulkin have identified people within the VA to get out there and do, and advertise and try to make those connections. And on a local level, in my district, the same thing. And I'm looking every day. I need I need help from the folks on the outside to reach out for me also, because here I am one target. But if you contact me regarding an interest, we'll work it. We'll get that.
If you identify a rural pilot grant, we'll apply for it.
The office of, the VA Office of Rural Health
Yes.
is the place to apply for funding. I don't know if they've got a current funding cycle, but also you can look on their website to see if they've funded any other legal projects before. But just from what your conversation here, I would say make sure that you frame this so that it is some kind of pre-legal kind of situation. In other words, you're trying to prevent the introduction of the veteran into the legal problem, and you're trying to prevent homelessness, and you want to include a broader population of both eligibles and ineligibles, but you have to also make it so that it's scalable. In other words, so that your pilot here in West Virginia or other parts of Appalachia develops elements that can be then scaled at a larger level and go nationwide. That's one of the biggest problems. Some of the smaller projects don't get funded.
And the big takeaway from medical legal partnerships is that they definitely do. The evidence is in, the data is in, that they significantly improve housing, income, and mental health for the veteran. It's without a doubt already been established.
And we've been trying to change the SSVF for a long, long time in terms of eligibility so that the bad paper folks can get into that system.
And there is funding now through SSVF, in theory at least, for doing discharge upgrade work. I also want to mention there is also, I don't know if you're an LSC-funded organization, but there is a Senate bill and a House bill currently pending that would fund medical legal partnerships and things of that nature. I think Senator Manchin from West Virginia is one of the sponsors, along with Senator Burr from North Carolina. My personal understanding is that the House is expected to be the bigger issue, so you might want to contact your House legislators if you support that.
The House is not rural. The House is not rural. Always remember that.
And from a really quick personal story, when I first got to the VA, I met a veteran on my way out of the door one night, and he was enjoying, I guess I thought he was enjoying the summer evening, and asked me if I could help him get a will. Then he was dying, and he knew he was dying, and he needed a will. And here was a guy not with a lot of worldly possessions, but just wanted a simple will. And of course, I knew how to do that, but I couldn't do that because he wasn't my client. The VA is my client, and I couldn't break the rule there. And it took me a difficult amount of weeks to try and find a local attorney to do that. But we did, and he did. And ultimately, unfortunately, he did pass away. But I often think back that I was able to help him, in the last portions of his life, be a little bit more calmer and not have to worry about, another issue. He could just concentrate on his family and him, and he didn't have to worry about a will.
And that is one of the effects that they talk about in a medical legal partnership.
Absolutely. Yes, it works.
Survey.
Well, the bigger deal, though, about medical legal partnerships is that the legal problem is causing your health care problems, right? So you live in a...
Or exacerbating it.
Or exacerbating
Sure, yeah.
So you live in a place and you get your electricity turned off and your medication has to be refrigerated, or you have a nebulizer, or you're living in an apartment and you've got lead paint and it's causing asthma, and the doctor is treating the child and treating the child and treating the child, and the child working on the symptoms, the child just keeps coming back and presenting with the asthma. The child has to be out of that house and move to a safer place. So sure. I love doing the back end will stuff, but what would be really effective, and what Elizabeth and I are talking about, is addressing the legal problem that is exacerbating the healthcare condition so it can actually be treated.
Yeah. And a lot of times, though, the patient is presented and these things are in full development.
Right.
They ignored it. They ignored that summons. They ignored that notice. And next thing you know, they come to us, and it is a panic.
Yeah.
And that's really unfortunate
Yes.
because they don't have any, they think they have no place to go. Again, we have to get out there and tell them there is a place you can go to. You can tell us, and that's how I think we also have to address it. Education and availability, access.
So I want to ask one question on the sort of future of healthcare, just to give everybody, because I think that's the topic that's going to get the the short portion of the program, and then if anyone has questions, we can get to the questions. But I was kind of interested. One of the issues that came up yesterday was some African countries that sort of skipped a developmental infrastructure stage, and sort of now the cell phone is everything, and so they were sort of in a better position to meet to go to the next step in terms of commerce and things of that nature. And so either on that topic or any other issue, there's been a lot of issues about broadband and things like that with infrastructure in West Virginia and other areas that include rural populations. Where do you all see healthcare headed, and what would you like to see addressed? And I'd like each of you to weigh in on that if you have an opinion.
Okay. I'm just going to go back to what I started talking about in the beginning, which is substance abuse treatment, behavioral mental health. And what I would like to really see is this shift away from the old stigma prohibition view that it's a law enforcement issue that deserves punishment, to a destigmatized, it's a healthcare issue that deserves prevention and treatment on the front end. And the analogy that we always make when we're talking about that is we wouldn't say to a diabetic, you can't have insulin for the rest of your life or get some kind of treatment, but we say to addicts, you gotta go cold turkey, throw them in a jail cell, et cetera, et cetera. And we actually create a condition there where when somebody goes back out and uses, they're more likely to OD because their tolerance is down, but they still have the craving and the addiction. So the future of healthcare, my little world that I live in, would be to start to treat mental and behavioral health issues as legitimate healthcare issues that deserve prevention and treatment up front.
Ms. Heimbach?
I'm starting to see signs of it in healthcare delivery, both in a hospital, in a nursing home, emergency departments everywhere. I would like to see more involvement of true patients' perspectives when policy making is going to occur. We say it, we pay lip service to it, and we have advocacy groups at the table, but that's not patients.
Right.
And I think patients and families and caregivers need to be involved when healthcare policy is formed going forward.
Right. And I agree completely. I think that the patient end of the picture has been the totally ignored part, needs to be brought into as a full member of the team on positive outcomes. And that includes, direct services, clinical services. It includes, IT, the whole spectrum. But in looking at the VA picture or the veteran picture for the future, I really want us to pay more attention to the largest growing segment of our homeless veterans, which is women. And most of the women who are there, not necessarily homeless because of drug problem, but homeless because of psychological issues that resulted from military sexual trauma. That is not a diagnosis. It is an event that can lead to diagnosable concerns. And so right now, our greatest growing population are childbearing age women with children in tow who are going homeless. And we have, in our entire homeless system in the United States has been geared up for homeless men over the age of 50. And so that picture's got to change. And in terms of access, I would say we need to continue to educate more, do more homegrown programs of our own people to get into the various professions that we need in those communities.
I agree with all the panelists and what they said, but we'll address, obviously, we need to continue to develop technology for the VA using what we have in order to catch as many veterans in our system as possible, eligible veterans, and to break down those barriers for them to get in. In relationship to the women's veterans issue, the VA's put a very significant emphasis on reaching out for women veterans. In fact, our facilities, at least in Clarksburg, I can tell you, we have a women's clinic where it's strictly it's not run by women all the time, but it's for them. We want them to feel comfortable in that environment and address those issues. So yes, could we be in the forefront of these? Yes, we can, and we are, and we try.
Thank you. Did you have any questions from the audience? Yes.
I want, you were talking earlier about the way that some of the physician shortage in rural America is, there's been a variety of strategies, everything from kind of rural rotation for medical students, and of course there's been more osteopathic schools opened up. One thing kind of growing up in Eastern Kentucky where federal qualified healthcare center was basically just the de facto way that we all got healthcare in the area. When I was young, there were a lot more foreign medical graduates that came. I think it was maybe like the J1 visa exemption program or something. I've noticed that there don't seem to be as many foreign medical graduates coming into at least Eastern Kentucky now as there were decades ago. Is that because there's been some policy change with that visa program, or is it more about that there's essentially been the local people or whatever that they've kind of been filling those positions?
Well, it's both things, and it's some 9/11 pressure, quite frankly. But the bigger deterrent, especially where you are with your, your Rural Health Development Center in Hazard, is that we are recruiting more American-born folks into those healthcare fields. And when we do have rural health programs to educate them, then that's why you're seeing them.
It's my understanding also that from the VA's perspective in credentialing and having these folks being able to work in our facilities, that if there is a non-J1 visa applicant, that they will be given the first consideration. Obviously, we'll go to the J1s after we can't fill. I guess even they might have great credentials and great education. That's just the way the law says that we have to consider it. So that might be part of the issue also. Yeah.
That center is wonderful, by the way. I know the fellow that started it. And your physician there is just...
Any other questions? Yes.
We talked some about preventative health care and taking care of things from the front end, and I love that idea. How do all of you think that we get there? Is it a matter of policy and law change? Is it a matter of education? How do we get to that point where we're advocating on the front end rather than taking care of the problem on the back end?
Reimbursement.
Yeah, I was gonna say, one challenge is the insurance industry. It's gotta be,
Yeah.
it's gotta be law, policy impacting the requirements of coverage of insurance on the front end.
I mean, it does no good to get Congress to change the law if the money doesn't follow it.
And the VA doesn't run on reimbursable health insurance, although we do.
Right.
There's certain situations where non-service connected injuries are, if you have insurance, we'll collect through the insurance. It's part of the business model that we have. But I think there's better communication. I don't think people realize that the DOD healthcare system and the VA healthcare system aren't the same thing, and we sometimes don't talk good to each other. But there's a big emphasis on trying to find those folks that are getting discharged with injuries and bring them into the VA instead of starting all over again and trying to establish a healthcare a basis for them and all that. We need to know how they are coming in. We receive them. We need to go out there. When I came out of the Army in 2004, I didn't even know the VA existed. I mean, I stepped off the plane and I was done. That was it. Here, you're finished, 20 years and you're done, kind of a deal. And I thought, well, okay, well, I better go get a job. I better go do something. I didn't know I could go to the VA. Didn't know I could go to the VA until I came to work for the VA. So that was a misstep on my part. Maybe I didn't ask the right questions, but heck, maybe they could have made a little bit better effort to hand me a card and say, hey, give this guy a call.
Huge effort to do a really thorough physical screening up front, mental health assessment, and physical
No,
screening.
you want to go home? Here,
You wanna
sign
go
this
home,
and
see you
leave is
later,
basically what they
and
tell
that's
you.
it.
Yeah.
And they know a lot of these folks have already been diagnosed in service with things or when they've returned from a deployment.
Right.
So you have a captive insurance and reimbursement and all this stuff on the civilian side, that's gotta be fixed. But we have folks who have served the country that are sitting there in this healthcare system that have to go through an out-processing program. What better place than
Perfect to
do it
catch
that
them.
way?
Why not at the end of that line, somebody at the VA saying, hey, come over here and sign this one-page application. It's one page, and that's all it's needed, but it's not being done for some reason, or it's not being done to the extent that we need to. Or the veteran is getting off that plane, and they're saying, you really want to go through a physical? Okay, just everything okay? And they're like, I have no problems, and that's it. And they want to get on with their life and get on going. And that's what we have to break down that.
And can I just add on I think one of the interesting things about the reimbursement issue is the VA, as you mentioned, it's not fee-based. So they've been able to do things like telehealth. You look at actually one of the least accepting places of telehealth has been Medicare, who has had a lot of restrictions and is sort of slowly winding them away, slowly letting them down. Like, because when I sort of initially thought about telehealth, you think of like being on a conference call with somebody, but it's also monitoring devices and things of that nature. It's saved data, which Medicare has really restricted the usages of that, which for places such as rural areas that are much more reliant on Medicare, it adds to that financial strain and also reduces its ability to embrace things like that, which really do help with monitoring chronic diseases. Yes.
Oh, the VA is really, really pushing telehealth, obviously, and you could talk to a provider on the West Coast and be in West Virginia, but it's not just, MD. Our pharmacists and other clinics are also involved in the telehealth, and they will talk to a patient, how's your medicine going, and they can see them back and forth, and they actually, as you said, have these remote ancillary devices that can tell what's going on. We provide for the patient, and it provides us with data and feedback as to their current physical condition. So, very, like you said, we're beholden to that healthcare industry or that insurance industry paying us back for it. We luckily don't have that.
Do you have a question?
Yeah, first, thank you so much. I learned a tremendous amount in this panel. Two things. I think it's super interesting that none of you said comprehensive universal health care coverage, right, in response to the last question, because it seems to me that would, right, it's not particularly politically palatable, but if everyone had access to comprehensive, preventative, high-quality health care, we wouldn't be playing these who's in and who's out of healthcare games, which we are right? Like, you have a whole panel of experts trying to figure out the rules about who's in and who's out, right? It seems to me a huge waste of many of your valuable time and resources. The other thing that I'm just gonna say up front is, I represent folks who aren't vets, who are conceptualized as far less deserving than veterans, and I get nervous listening to the way that we narrate veterans, because I think we narrate them as, and I believe they are deserving, but I believe everybody's deserving. So I would feel remiss if I didn't call attention to that narrative in the way that this conference, right, they've served our country, therefore they should get this or that.
But those people would not be veterans if they did not come out of that environment. You're right, everybody is deserving of that, but we've got a broken system that's got to be attended to before we get to universal health care. It just won't politically, it is not realistic.
I just want to say this. I completely agree with everything that you said. And at the beginning, try to tie in the coal miners and the other manual laborers, because you're seeing the exact same dynamic, right? But more importantly, and that's my big issue with VA, why can't VA cover every veteran? We can't even do it there. That's my big jumping up and down point here, is that we spend so much time when we get the screening people on. They have all these interesting programs, and there's wait lists for different ones, but the screen and the criteria is different for every single one. And when we have a person in crisis that's had an issue, that has that mental health issue or whatever, 9 times out of 10 they're not eligible for most of the stuff. And we have to, and I'm in the exact same situation you are.
We have to
elect. And the American people think that we're providing veterans that health care, and we're not.
Right, we've got to elect people that will do it. When I was working on the 2006 Rural Veterans Act, I literally had a staff member with from a very powerful senatorial office tell me, his words, well, we just cannot provide care for everybody. There are people that go into the military and do their 4 to 5 years of service, and then they believe they're entitled to something. This was the chief staff of a member of the Veterans Affairs Committee.
I personally will not be satisfied until every eligible veteran is in our system and signed up and receiving health care. And I do agree with Professor Oliva and the rest of the panels that, in fact, I think, from a personal point of view, that everybody who puts on a uniform and has served honorably should have access to health care. And I believe that the VA's healthcare system does qualify under the law regarding universal access, Obamacare, whatever you want to call that, American the law. So yeah, right. So we try, but from a veteran's point of view, if you've put on a uniform, I need to see that you're taken care of. I can't, I really don't put a differentiation between whether you served in the Guard, you never left the United States, or you served 5 combat tours in 4 years. I think it's all the same. You raised your hand, and you said that you would defend. And that, to me, is a little bit different than some other things. But, I mean, from my perspective, and I deal in my area, that's who needs to be in our system, without a
But
doubt.
that still treats healthcare as a privilege that you have to earn.
Okay.
We need to expand or redefine honor.
No, and still dealing with the populations that aren't those who served, because there are Medicaid populations, there are children,
Right.
there are families,
Right.
there are low income, and we're in the middle of it. West Virginia is the entire state is in Appalachia. And that challenge is an uphill battle for a very long time.
I think we're out of time, so I want to thank our panelists for a very fantastic discussion, for making my job as a moderator very easy. I appreciate it. Thank you.